Okay, good morning everyone and welcome to today's live demonstration. My name is Alexander Nikolic. I'm all the way from sunny Cape Town. This is Liza. We've already managed to have our pre-treatment consultation in a room next door. And also just to prepare, because of time constraints, I've already made some skin markings as well as some vital structures. One of the things that Liza definitely complained about when I asked her what concerns her is she pointed predominantly to this area and felt that this area is making her face look quite drawn. When I examined her and pointed out that there are some, if we can have a closer look, there are some other areas which contribute to that drawn down appearance to the face, especially the flattening of this mid-cheek area. We can also see that this is really not that depressed. It tends to be more on movement that one can see those depths of the actual dimple that take place. There's a slight downward turn at the corner of the mouth as well as this pre-sulcus area, and we can exaggerate that by showing where that skin wants to fold in because of the underlying laxity or the loss of support of the fatty layer. Another area which is often forgotten when we are examining our patients is to actually look at this temporal area, and we can see a definite step at that or the superior margin of the zygomatic arch. Now, these are the lines or the skin marks I normally make when I actually treat a patient. And just yesterday, we had a training with some of the local opinion leaders with Massimo, and I must be honest, Massimo has a very simplified approach, and what I will show once we've wiped off the anatomy is how I actually got to these skin markings. So because we've decided to treat the temporal area, the mid-cheek area, the lower cheek area, as well as the melamental fold and the pre-sulcus depression, we need to understand that there are certain vital structures that we should be concerned about when treating that area. And I think the biggest fear that everyone tends to have is the facial artery. Now, it's a very, very simple artery to identify. We can see that this is the anterior border of the actual masseter. We get that by asking our patients to clench, and just in front of that, we can see that the facial artery, which follows a fairly tortuous route to the lateral aspects of the alonasal sulcus. It then travels alongside the nose and becomes the angular artery, and at the bridge or the radix of the nose, it turns into the dorsal nasal artery. It does give off branches, including the superior labial and inferior labial and inferior labial arteries. The importance of this structure over here, the dorsal nasal artery, is that it is a direct branch of the ophthalmic artery. And this is definitely an area that we should avoid when injecting or treating patients with fillers. The facial vein typically is found slightly lateral and a little bit more superior to the facial artery, and we can see if we're going to be treating this area that we are concerned with the facial vein. In this area over here is also the canine, is also the infraorbital foramen. There's a lot of individual variation of that infraorbital foramen. We typically taught that it's in the mid-pupillary line. Open the eyes first, Liza. In the mid-pupillary line. And if we feel with our fingers, we can feel quite a firm ridge here. That's the frontal process of the maxilla. Just below that is almost a depression. And that depression is termed the canine fossa. And typically, that's where we find the infraorbital foramen from which the vessels as well as the nerves emerge. When treating the temporal area, the biggest concern is that we don't inject the superficial temporal artery or the deep temporal artery in this area. And typically, that's located very simply by palpating. My advice is that we don't palpate with our gloves on, but rather take your gloves off, and then one can actually feel or palpate that region much easier. We also decided to treat the glabella region. Frown for us, please. We can see that there's some movement of these areas. Relax for us. And what I've just drawn in very quickly is the muscular anatomy. The procerus, the main action of procerus is the downward pull of the brow area. It's attached to the nasal bone, and parts of some fibers come from the nasal cartilage. It then extends superior to insert itself in the skin as well as into frontalis. The corrugator has a deep and a superficial part. The deep part is attached to the medial aspect of the supraorbital notch. It then travels slightly superiorly and obliquely and it becomes more and more superficial until it inserts itself within the skin as well as in the underlying frontalis fibers. Frown for us again. Thank you. Okay, I'm just going to wipe all of these anatomical skin marks, and then we'll start with the actual Glabella, the Vistabel injecting. I also like when I do Vistabel for the patient to be a bit low down. Okay. Do you want me to wipe? Or? Okay. No, leave the skin marks because those are the ones we're going to use. Okay. Just the, yeah, so that's fine. Just the anatomy. Okay. Yeah, thank you. Is it coming off with difficulty? So these Johnson wipes actually work very well to wipe that pen mark. Oh, okay. Let me help you. Let's get. Now, many of us have different preferences when treating our patients. Some of us like our patients to be upright. Some of us like the patient to be a little bit flatter or at a 45 degree. You know, I only have two positions when I treat a patient. It's literally almost flat, and that's typically when I'm doing my Botox injections, as well as when I'm augmenting and defining lips and treating the Glabella region. But typically the rest of the face, I tend to treat, as if you can just sit up, with the patient sitting almost upright. Thank you, Liza. You can lie back for me. Just an alcohol. We're going to make our skin marks. If you can come a little bit lower down so we can actually see. We're going to make our skin marks specifically for, just the pen, for the glabella complex, and we're going to be completely on label. We're going to use 5 injection sites. Frown for me, please, Liza. I like to inject in the very central part of procerus. Typically, relax for me. Typically, the deep or belly of the corrugator is identified in line with the medial canthus, which we'll do there on both sides. And we tend to individualize the tail end of the corrugator. Frown for us. And we can see the movement of the skin, and on either side, relax. We will treat the tail end of the corrugator. So for the first injection site, I always treat the procerus. It's going to be 4 units in total. Needle going in. The next, we're going to treat the right deep belly of the corrugator. Frown for me, please, and relax. I like getting the patient to frown so I can grab the belly of the muscle. I then can clearly feel that I am in the muscle. Another 4 units. I get the patient to frown again. Frown, relax. And again, just above our skin mark, we inject, needle going in, and it's directly in the belly of the muscle, and that's another 4 units. The next 2 injection sites have to be superficial, very simply because the fibers insert in the skin, as well as the fibers of frontalis. With this, I tend to stretch the skin. It helps to support not only the entry of the needle going in. I like to create a little bleb, and that's another 4 units. It also, to a certain degree, helps control the comfort level that the patient experiences. Needle going in. Very superficial, so we can see a bleb, and last 4 units that have been injected. Sorry. Okay, we're going to move on to making the skin marks for treating the right side of the face, and just explain what my approach is there. I just want to do this as well. I'm going to come that side. turn towards me. When I approach the medial aspect of the cheek, I immediately identify where that actual depression is, and I like identifying where that actual depression starts and where it ends. Turn towards me. I then draw a line from the corner of the mouth to the top of the ear. And what this line represents is that I don't want any product below that line. It's the most inferior aspect of the cheek. I can just put my finger there. I then draw the natural anatomic outline of the patient's own cheek. And for me, this is the guideline. When I come to the melemental fold, I actually like to show where the greatest degree of laxity is seen, and I draw the lines between that, as well as in the presulcus depression. And there's a slight depression or shadowing taking place in that part of the chin area. When the most important aspect that we need to concentrate on with the temporalis really comes with feeling the temporal fusion line, the superior portion of the supraorbital notch, as well as the superior aspect of the zygomatic arch. Then we need to palpate the temporal artery, gloves off, and I normally draw a cross and follow the pathway of the temporal artery. I'm going to start off with the cheek area. Can I just have the pen again? No, it's okay. It's okay, I don't need it. Thank you. No, with the cheek area, the preferred product is to use Juvederm Voluma. It's an on-label indication, specifically for that area. I'm going to most probably treat 2 or 3 points on the cheek area using a bolus technique. That's my preferred approach when treating the cheek, but one can use a needle or a cannula. It really is dependent on the doctor and what makes them comfortable. Sorry. We're going to start off, chin up a bit. We're going to start off by treating the flattening of the central part of the cheek, the flattening of the medial aspect of the cheek, as well as the flattening of the superior portion of the medial, as well as the deep malar fat pad. Oh, this is too small. I need large. Okay. Sorry? On. Yeah. Please. Is this Voluma? Now, when injecting, I really like using a distraction technique very simply because it helps to control the comfort level of the patient. Chin a little bit up, slightly away, that's fine. Typically, I grab the tissue between 2 fingers, and with this index finger, I tend to tap on the skin. This is where my first point is. I also like to use the zygomatic arch as a support, as a structure, and I feel the angulation. Can also have another wipe with alcohol. The angulation of the actual arch. Thank you. First injection, Liza. And I always tell the patient, needle going in, and you can see that distraction technique, and hopefully I move all the way down to just above periosteum. I then use the non-injecting hand between these 2 fingers to lift the tissue, and by doing that, we remove any vital structures away from the actual bevel of the needle. I typically inject until I can actually feel the product pressing between my 2 fingers. I immediately mold the product. We could see that bolus and how easy it is to actually mold it and give it the shape but also importantly, this ensures the uniformity of the product. It's fine. It ensures the uniformity of the product and giving us a very natural result at the end. Alcohol. We're going to move to the next point. We can just use. We're going to move to the next point. The next degree of flattening is taking place. Again, I'm using my index finger, needle going in. The distraction, I'm hoping, is working very nicely for Lisa. Again, do you notice how I'm removing the vital structures by lifting the tissue? I want everyone to see that bulge. Immediately we can mold and give that area the desired shape that we were trying to achieve with the actual cheek. We're doing our third point, which is slightly higher. We're moving slowly towards the deep malar fat pad. How are you doing, Liza? And again, between two fingers, distraction, needle going in. It's just above periosteum. It's very moldable and malleable in that area, and we can give the shape. And the last and final injection, which I need another volume for, is going to be in the deep malar fat pad, and this will help to reduce the appearance of the slight or very minor tear trough depression. That's gone off. This iPad's gone off. Okay, so we're trying to give that area a slight degree of fullness. Again, alcohol. I'm a big fundi when it comes to the use of alcohol. This is a standing joke among my patients that tend to get high, and I think that it actually helps with the anesthesia. But it's extremely important when we're injecting at this level that we remain as sterile as possible. I like to, because this area is sterile, I can place the needle, and what I'm trying to do here is to determine exactly where I'd like the product to be, and where the hub touches the skin is where the needle will enter. This is the area that we will need to aspirate to ensure that we're not in any vital structures. Is that alcohol? Or I've got. So just below the aspect, superior aspect of the infraorbital rim, needle going in, and a deep angle. We want to get to that adherence of the bone. We need to aspirate, and until you see, when we see that bubble, we know that there isn't any blood and that we're not in any vital structure. It's very important to inject as slowly as possible and feel or palpate with this finger until you can feel the filler material giving support to that deep malar fat pad. Draw. We can then again mold and shape and place the filler. This is a sensitive area. You can warn your patients that the molding can be sensitive and sometimes more painful than the actual injecting. Okay. Now, with the temporal area, I have a fairly simplified approach, and the main reason for that is I'd like to go as few times through the skin as possible to prevent any bruising. I like also to place the filler material. We can use this for another area if we can have a whole volume. Yes. Is it possible to have that light here because of these veins? There's a lot of vascular structures. And I think this is a very important learning curve here. you know, in some people there's very few veins and they're very easy to see and we can miss them. But I think that when you see an increased vascularity, try use as good lighting as possible, because that will actually help to identify. I even sometimes work through the actual magnification itself to identify those tiny little veins, so that we can miss that area or miss all those tiny veins and reduce the chance of any bruising taking place. Oh, it's not, okay. That hasn't altered the camera, good. Now, this temporal fusion line is a very important line because the temporal fascia inserts itself there and it doesn't allow any product to enter into the forehead. So the first thing I do, again, distraction technique, needle going in, all the way down until we touch bone or just above bone. Again, it's on there, huh? Okay. Again, withdraw until we see that bubble. Support the skin, and this area we need to inject very slowly. How are you feeling, Lisa? Do you notice how slow the plunger is moving? That's very, very important in this area. It improves the comfort level for the patient. And we can slowly notice a bulge that's appearing where we're injecting. It's still okay, Lisa?
Yep.
Okay. I'm going to pull out. This is another advantage of using volume in this area, is that we can see the product has collected, but just with a little bit of gentle pressure with my finger, we can move that filler material further down and slowly improve the appearance of the temporal area. We can still see a slight depression in the superior aspect of the zygomatic arch. You can just have another, not a new volume, but one of the open ones. The one with the straight needle. And here we can go in this region over here. Thank you. Perfect. Okay, we've just changed the needle. It's a fresh needle. That improves the comfort level because the needle, because they're so fine, they can be quite blunt. And we just improve the comfort level for our patients. Again, check very carefully for the actual veins in this area. We want to try and reduce the degree or amount of bruising. And again, needle going in, Liza. Push it. That's fine. And again, we need to withdraw in this area. It's a very, very, and only stop withdrawing until you see that bubble. We then inject very slowly to enhance this depression. The reason for the slowness is to reduce complications. Side effects are increased. The faster that we inject, that not only means the speed at which the needle moves, but also the speed at which the plunger is pushed by our fingers. Again, we need to mold and give it a little bit of shape. This also ensures the uniformity of the product. And by avoiding those little superficial veins, we can see that with 2 injection sites, there's hardly any bruising or evidence of a treatment in this area. I'm going to move on to using Glabella, and this is specifically to help lift the corners of the mouth and treat any depressions and fine lines. It's also a very, very good filler to use, and especially specifically indicated for the lip area, including enhancement of the vermilion, as well as the vermilion border. So here again, we're going to use the distraction technique. We're trying to lift and support the corner. This is the first part of rejuvenating the lip. Needle going in. And slowly, as we push forward, I like using an antegrade progression, depositing the filler below the lip corner, giving it as much support, and taking away that downward turn to the actual or appearance. And again, you can see I'm immediately giving a molding and a pressure to that area. What's unique about Glabella is its low hyaluronic acid concentration, which makes it very malleable and also very easy to push through the plunger. So we need to reduce the force or pressure. We can see a definite improvement of that area, but still a slight depression that we would like to improve. Needle going in. Slowly push the plunger forward and the needle to improve the support in that area. Again, we need to mold, give it its shape to further support the area. This slight depression over here, we're going to treat superficially with a bit of Glabella. With Voluma. That's the fold. That's where we would like for it to support. Needle going in. And just gently below that skin, slowly we're going forward. And we're just giving it a little bit of support to that underlying tissue to remove any shadowing or depressions that one can see if we had left that alone. Need a little bit of Voluma left. And the very last and final injection that I'd like to do to treat is this slight pre-sulcus depression, just to help support the skin. Here I'm using Voluma, and again I'm going to approach it from a bolus technique. Lift up. Again, we can see where that depression is and where we would like the support. I like to place the injection quite deep here. Distraction, needle going in. Slowly push it forward, deposit the actual filler. We can see and even feel that depression filling up. You can see that bulging of the Voluma product, and this is again just to demonstrate how easy it is to mold it and to give it its shape, but at the same time to improve the uniformity of the product. Let's wipe. I wanted to show that, yeah. Can I just wipe all the...
Of course you can. You want this wiped off as well?
Yeah, all this. And on the other side.
I will do this if you want to carry on.
Okay, so I just want to finish off by showing you the two sides. We've had to treat one side. We will treat the other side in another room. You can just sit a little bit forward. Okay. What I'd like to be able to demonstrate is the enhancement of the central and medial aspect of the cheek, the enhancement of the temples, especially if we compare the two sides. Sit a little bit more up. Just the head forward. That's it. Thank you. We can see a slight improvement of the melomental fold and a straightening of the actual corner of the mouth, as well as an improvement of the jawline, where there seems to be a much straighter line to that jawline as opposed to the other untreated side. Thank you, everyone. That's the end of my demonstration.
Wow.